Hello, everyone. Welcome to the Arthritis National Research Foundation's Researcher Spotlight webinar series. I'm Jenny Dunn, Senior Director of Marketing at ANRF, and on behalf of our Board of Directors, Scientific Advisory Board, and staff, I would like to welcome you to the Spotlight series on osteoarthritis. We are so excited to have so many of you joining us from all around the world. Before we get started, there are just a couple of logistical pieces of information I want to share. This webinar is being recorded and we will have it available on our website and YouTube channel in the coming weeks. And then if you have questions, please do type them into the Q&A box. If we aren't able to get to yours, you can also email us at info@curearthritis.org. And after the webinar, we'll try to get your question answered. I'm now very honored to turn the mic over to our patient moderator, Jenny Weaver. Welcome, Jenny, to tell us her story of living with osteoarthritis.
Well, hello, everyone. My name is Jennifer Weaver, and I want to start out by telling you that I am a patient leader living with a couple of different conditions, actually. So I have rheumatoid arthritis, pustular psoriasis, and my newest diagnosis is osteoarthritis. And so my work centers around building community, educating, and advocating so that people with chronic illness feel supported, seen, and empowered. And all of this began back in around 2010 when I was, dealing with some uncharacteristic, how do I phrase this? Different kinds of pain than I'd ever had before. I was 30 years old, raising 3 kids in middle school, and nothing prepares you for waking up with your joints hurting. And it took about 2 years to get a diagnosis. And of course, that was rheumatoid arthritis. And we fast forward, I had an allergic reaction to one of my medications. It was a TNF inhibitor, and it activated pustular psoriasis inside my body. And so that became my second diagnosis. Well, this July, so very recent, I found out that I also have osteoarthritis at the age of 45. And that kind of is a little bit about me and why I do what I do, because I don't want any of you to ever feel alone. And so where I'm leading next is I want to actually introduce Dr. Alexander Knight, and he was trained as an immunologist and recently started his own laboratory at Washington University in St. Louis, where he is based in the Department of Orthopedic Surgery and Center of Regenerative Medicine. His lab studies how cells in our joints communicate with each other and how the breakdown of these communications leads to the onset and progression of osteoarthritis, with the ultimate goal of preventing or reversing disease. So hello, Dr. Alexander Knight. How are you today?
Very well, thank you. Great to be here.
Well, I think we're turning it over to you now.
Super. Yeah, well, thanks so much for the introduction, Jenny. Good morning, good afternoon, good evening to everyone in the audience, depending on wherever you are in the world. It's fantastic to have the opportunity to speak today. I'm going to tell you a little bit about my research on osteoarthritis, and hopefully you find it both informative and interesting. So first of all, defining osteoarthritis, or OA, is quite difficult because every patient manifests in their own unique way. But broadly speaking, OA can be defined as a debilitating chronic joint disease characterized by pain, stiffness, swelling, and a gradual loss of function. It can originate from a genetic predisposition, through aging, or from environmental events like a joint injury, for example. And typically, though, these different causes don't just act in isolation. They all contribute in some form or another. And OA can affect different joints. Although it's most commonly found in the knee, the hip, the shoulder, it can also arise in other joints too, like the hand and the spine. OA is very, very common. It now affects well over 30 million Americans, and this number is constantly growing. Women represent a larger share of those suffering from OA, but really the disease affects both sexes, and it doesn't just impact the aged population. In fact, the disease burden of OA has grown so substantial that there was a recent white paper published calling for OA to be officially regarded as a serious disease, both in terms of its scale and also its severity. So if you suffer from OA, whether in the early stages or later stage, what can you do about it? Well, the first course of action, without a doubt, is establishing a healthy exercise routine and managing your diet. These are proven ways to benefit overall health, especially since metabolic disease and obesity are such major risk factors for OA. And beyond this, improving diet and instilling regular exercise habits also can have a direct beneficial knock-on effect for your joint health. And it, of course, goes without saying that devising an appropriate lifestyle plan is best done in consultation with a professional, whether that be a primary care provider, nutritionist, personal trainer, physical therapist, some combination of all of the above. And although I fully agree with the phrase use it or lose it when it comes to joint health, it really is critical to ensure that you're using correct technique when performing exercises, and you're doing the exercises that are appropriate for your unique situation. The last thing you want to do, right, is to worsen your condition or potentially injure yourself. And I'd like to shout out one really fantastic resource for learning how to manage your disease, and that's the Joint Action podcast. It's run by an Australian rheumatologist and OA researcher, Dr. David Hunter, and it's very accessible and informative for patients, carers, physicians, and researchers alike, especially for the latest developments in OA-relevant research. Now, when it comes to treatment options, the unfortunate reality is that there are no approved disease-modifying drugs for OA. Yes, medicines can be prescribed for symptomatic relief, for pain or swelling, and there are end-stage joint replacements, which are another option, but there is no cure, which is why there's such a strong impetus for researchers like myself to discover new targets and new treatments. There are experimental treatments and supplements marketed for treating OA, but it is worth noting that none have actually been proven to stop or reverse the disease progression. And in some cases, these might be counterproductive or even damaging in the long term. So my advice is to be very discerning. Now, before I dive into my research proper, I want to provide just a little bit of background on my scientific journey so far. As you might be able to tell from my accent, I grew up in Sydney, Australia. I studied immunology and biochemistry for my bachelor's and my PhD. And then afterwards, I moved in 2019 to the US to do my postdoctoral training at the University of Michigan. And this was really where I first started to become interested in joint diseases and began to study osteoarthritis. And then earlier this year, I started my own research laboratory at Washington University here in St. Louis. And this is where I live now with my wife and 2 sons, and there's another little one on the way in a couple of months, which is very exciting. And so over to what my lab studies. Well, we're specifically interested in post-traumatic OA. And this is where you have a healthy joint, and then it undergoes some sort of injury or trauma. And this could be a fall, could be a sporting injury, and then this person goes on to develop OA eventually. So the primary focus here is on preventing the onset of disease after the injury event, stopping people from going on to develop OA, and instead helping their joint to properly heal and restore its normal functions. But of course, this doesn't help people who already have OA, okay? Maybe they developed it spontaneously with age, maybe there was no defined injury event. And so in these scenarios, we shift our focus instead to developing regenerative strategies so that we can halt and reverse the disease, ultimately with the goal of fully restoring structure and function of the joint. And I have to say that this is no easy feat. After all, joints are highly complex organs. They're comprised of hard tissues such as bone and cartilage, and also various types of soft tissue. And all of these different tissues are constantly interacting or talking to each other. And during disease, when people develop OA, these normal, healthy interactions start to break down and go awry. And while the inherent complexity of joints makes them very fascinating to study from a scientific perspective, it's also kind of the reason why they're so hard to treat. Interestingly, many people aren't aware that we have fat in our joints, not too dissimilar from fat in other parts of the body. And we're only really just starting to scratch the surface of why our joints actually have fat in them. For starters, it's not entirely clear whether joint fat is the good guy or the bad guy in OA. Studies in humans have shown evidence for both sides of this argument. Plus, there's this inherent degree of variability in any human study, from factors ranging from BMI to age to sex. And these factors and variability make it very, very difficult to draw solid conclusions without a large number of patients, both healthy and with the disease. So to remedy this, to better understand the disease mechanisms in more controlled studies, we use animal models like mice. And the goal here is that we can one day apply what we learn in mice to help people suffering from OA. So in our lab studies, we use a mouse injury model of post-traumatic osteoarthritis, and we found that joint fat gradually disappears as the disease progresses. And what I'm showing here is a side-by-side histology of healthy joints and OA joints from mice. And you can see with the red outline, that is the soft synovial tissue of the joint. And within that outline, there are these blue pockets. And these little pockets are the fat cells, the joint fat. And what you can see and hopefully appreciate here is that the joint fat is greatly diminished in OA. And also, those with a keen eye can probably spot a large osteophyte that's formed in the right-hand OA sample. And these are also called bone spurs and are a major cause of joint pain in OA. So joint fat seems to disappear after an injury and as OA progresses. But why is this an important finding? Why do we care? Well, it's already known that joint fat plays an important cushioning role. It stops hard tissues from rubbing against each other and banging each other directly. But there's emerging evidence, both from our group and from other groups, suggesting that joint fat is also a beneficial source of stem cells, and it can also combat inflammation in the joint. Both of these are really essential ingredients for developing regenerative therapies to cure OA. On the right-hand side of the screen here, you can see an image of a human knee joint, and hopefully you can appreciate the scale of the joint fat, which is in yellow. It really is a key structure in the joint. So to conclude, although joint fat has long been ignored in the context of OA, we believe that it's a very important tissue and holds great therapeutic potential. And the goal of my laboratory is to harness these beneficial functions of fat to promote proper cushioning in the joint, also as a source of regenerative healing for damaged tissues, and to promote an anti-inflammatory environment in the joint where the stem cells can thrive. And the goal is that by employing this multi-pronged approach, we hope to improve the overall effectiveness of any regenerative therapies in highly complex joints. So with that, I'd just like to finish by thanking all the people and the funders that made this work possible. Team science and collaboration are really, really essential in this day and age. And I'm in such a fortunate position to have a talented team and to train the next generation of scientists. And I'm just going to finish by saying a big thank you to everyone for attending and listening. Thank you very much.
Well, thank you, Dr. Knights. And I just want to remind everyone attending, be sure to put all of your Q&A questions down in the little box with the question mark. And I know he's going to be happy to answer all your questions. That was some really good information. And next, I want to introduce Dr. Shouan Zhu. And he is an associate professor and the Osteopathic Heritage Foundation Ralph S. Licklider Endowed Professor in Orthopedic Research at Ohio University. Wow, that was kind of a mouthful. Dr. Zhu leads the Osteoarthritis Research Laboratory within the Ohio Musculoskeletal and Neurological Institute and the Diabetes Institute. His research focuses on how aging, obesity, and growth hormone influence cartilage cell metabolism and can contribute to osteoarthritis. He has received multiple national research awards, secured over $6 million in funding, and published extensively with more than 3,000 citations. Today, he will share his team's latest discoveries. I apologize. Here I am. Okay, latest discoveries and insights into the biological mechanisms driving joint degeneration and what they might mean for preventing or slowing the disease. So thank you, Dr. Shouan Zhu. I'm going to turn it over to you.
Thanks so much for the introduction, Jenny. Hello, everyone. My name is Shouan Zhu from Ohio University. Really thrilled to be here. So today I'm going to talk to you about some of our work studying the role of growth hormone in aging-associated joint degeneration. So Alex just did a really good job introducing osteoarthritis, recognizing it's a serious disease. So here I just want to highlight that osteoarthritis is a really complex disease. It has many risk factors such as aging, obesity, gender, injury, and genetics. And among those risk factors, aging and obesity are the two biggest risk factors for OA. So for example, on the right, this is a graph that was generated from a study that conducted by the CDC a few years ago on the US general population. And you can appreciate that there's increased prevalence of osteoarthritis during aging. And this number can be doubled if you have obesity on top. And this is true for both men and women. So our lab is interested in studying why we develop osteoarthritis during aging and also during obesity, these two conditions. So the strategy we have been using is to zoom into the knee joint and zoom into the cartilage tissue where the degeneration happens, and also zoom into the cells called chondrocytes, and looking at the different metabolic pathways inside the cells and see how they change during these two conditions. And with a hope that we can identify some molecules or proteins change during these two conditions. And then we can modulate those proteins either up or down to see if we can restore the metabolism and also the cell functions. And eventually we want put these results back into preclinical animal models to see if we can modify this disease course. So growth hormone is a hormone that is produced by the pituitary gland in our brain. So it has a direct effect on virtually all the tissues and organs in our bodies through the receptor called growth hormone receptor. It can also have indirect effect through another hormone called IGF-1, which is mostly produced by the liver. It turns out in our body, we need just the right amount of growth hormone to function normally. If we have too much growth hormone, that will lead to a gigantism. If it happens after puberty, it will cause a disease called acromegaly. If we have too little growth hormone, that will lead to a growth hormone growth deficiency, which always leads to short stature and other complications. So one of the most important roles of growth hormone is to regulate metabolism. So here's a picture I stole from my colleague, Dr. John Kopchik. basically showing a dose-dependent role of growth hormone regulating fat, muscle, and bone. And you can see that with increased amount of recombinant pig growth hormone, you can see there's increase of muscle and bone and also decrease of fat. And on a cellular level, growth hormone first bind to the growth hormone receptor on the cell membrane, and then trigger the cascade of signaling pathways inside the cells. So as I just briefly mentioned, growth hormone-related disease, if growth hormone is dysregulated, that will lead to different kinds of disease. So if there's an excessive amount of growth hormone after puberty, that will lead to a disease called acromegaly. So patients with acromegaly will have a enlarged feet and hands, and they also have disformed shape of their face, and also other complications. On the other hand, if you have a genetic mutation, rare genetic mutation in the growth hormone receptor gene, that will lead to a disease called Lamb syndrome. So patients with Lamb syndrome, they have normal amount of growth hormone. However, this growth hormone cannot bind to the growth hormone receptor properly. And these patients also have short stature and other complications. So here I have to introduce my colleague at Ohio University, Dr. John Kopchick. He has made some seminal contributions to the field of growth hormone. One of these contributions is to create numerous mouse models to mimic these different growth hormone-related diseases. For example, on the right, these are 4 mouse models they have created over the years. The first mouse is the BGH mice. So these mice overexpress a gene called bovine growth hormone, and this mouse model has excessive amount of growth hormone inside their body. So as a result, these mice are bigger. The second mouse is a wild-type mice. So these mice have normal amount of growth hormone, so they grow just normal size. And the third mouse, that's the GHA mice. So these mice overexpress a growth hormone receptor antagonist, and as a result, these mice are smaller. And in fact, this mouse model has been used to discover a growth hormone receptor antagonist called paclitaxel, which has been FDA approved to treat patients with acromegaly worldwide. And the third mouse model, that's a growth hormone receptor knockout mice. So these mice does not have the growth hormone gene as a way to model the Lamb syndrome. And these mice also smaller than the wild-type mice. So one consistent finding from the field, just by studying this mouse model, is that researchers found growth hormone can also regulate the lifespan of these mice. So here I'm showing you this survival curve. So basically, we raise these mice and then let them naturally die because of aging. Whenever there's a mouse died, and the curve will drop down a little bit until there's no mice left on this colony. So the solid line, that's the normal mice with a normal amount of growth hormone, and all the dashed lines on the left, these are mice with excessive amount of growth hormone. So these are mouse models produced in different labs worldwide. And you can see that the typical wild-type mice with normal amount of growth hormone can live about 3 years, while the BGH mice with excessive amount of growth hormone, they can live only about 13 to 15 months, which is only half of the lifespan of wild-type mice. In contrary, the growth hormone receptor knockout mice, they can live about 5 years, which is significantly longer than the normal mice. In fact, the growth hormone receptor knockout mice has won the Methuselah Prize, a mouse prize for longevity, and they also hold the longest-lived laboratory mouse in the world. So when I first started my lab at Ohio University in 2020, we were interested in collecting the joints from all these mice and to look how they develop osteoarthritis. As Alex just mentioned, mouse knee joints, they have similar structure as human knee joints. For example, on the right, that's the cross-section knee joints of mouse. And you can see that so we can use a special kind of staining. We can show the cartilage as orange and a red color here. And then the meniscus, that's a triangular shape on both sides. You also have a subchondral bone, as shown in the dashed line here. That's a piece of bone underneath articular cartilage. And then you also have the growth plate, which is responsible for the longitudinal bone growth. So the first mouse model, we looked at the BGH mice. So these two images are the small magnification of the whole joint of the BGH mice and the wild-type mice. You actually don't have to be an expert to tell that these BGH mice joints are pretty disorganized, does not look very healthy compared to the wild type. And if you look closer at each individual compartment, and you can appreciate that the BGH mice, some part of the cartilage are simply gone, which is indicated by the white arrow here. And then you also have other parts have these bumps and overgrowth of the cartilage. So we think these are early osteophytes. So they're on their way to become a piece of bone, as Alex just mentioned. They call osteophyte. Not only the structure is disrupted in the BGH mice, the cartilage quality is also pretty low in the BGH mice. So here we used a immunohistochemistry staining for a special kind of collagen called type 10 collagen. Wherever the type 10 collagen is present, it will be shown as gray color, as brown and gray color. So here you can see the BGH mice has a lot of type 10 collagen, indicates this cartilage is on their way to become calcified. And we can quantify the OS severity by using different scoring system. The higher the values are, the more severe the disease is. So you can see the BGH mice has really severe osteoarthritis going on in their knee joints. And not only the cartilage has been degenerated in these mice, so these mice also have synovatitis, which is showing overgrowth of the synovial layer. Instead of one layer of cells, they have multiple layers, indicating there are a lot of inflammation going on in these mouse joints too. And the piece of bone, which is underneath the cartilage, also become very thin in the BGH mice, suggesting that they cannot support their knee joints anymore. In contrast, the growth hormone receptor knockout mice, so these mice are smaller compared to the wild-type mice, normal mice. So we look at their joints at about 2 years old, and you can see that the wild-type mice at this age already start to have some degeneration going on the surface, while the growth hormone receptor knockout mice, their joints are completely smooth. In fact, we were struggling trying to find anything going on in this growth hormone receptor knockout mice at this age. And then the third mouse, GH3 mice, their mice similarly also are protected from aging-associated joint degeneration compared to the wild type. So we have published these two studies in two separate papers in 2023 and 2024. Basically, the take-home message is that too much growth hormone really isn't good for the knee. It seems also has some beneficial effect if you inhibit growth hormone actions inside the knee joint. So with that, I'd like to thank my lab, my collaborators, mentors, and friends, and also the funding sources, especially the grant from ANRF, which was my very first extramural grant I received after I established my lab. Thanks.
Well, thank you, Dr. Zhu. That was another fantastic presentation. And I just want to remind everyone that's attending, there's that box down at the bottom. It says Q&A with a question mark. That is where you want to put all of your questions. And I think we're kind of ready to start answering some of those. So let me see here. Okay, the first question we have, is there a relationship between OA and osteoporosis? That's a really good one. And this question is for, oh, nope, we have another question after that. So I think this one is open to either one of you.
I can kick things off here. it's actually quite controversial, the link between OA and osteoporosis. There are actually some studies which seem to show that people with OA may be somewhat protected from osteoporosis because of a higher bone mineral density. It's not confirmed, the jury is still out, but they are very much separate diseases that can coexist, but a direct link, causative link between the two, harder to pin down. Shouan, did you have anything to add to that?
Yeah, I agree. I don't think there's very clear evidence to showing one thing or the other. And I just want to say that there's actually a piece of bone underneath your cartilage is typically undergoing some constant remodeling during the OA process. And that is sort of just a small microenvironment of the bone, not the whole general bone. So I think it's probably also depends on where you're looking at the bone. Yeah, I don't know. It's tough to answer this question.
I don't know if I can speak for everyone, but I think just the words themselves, starting with osteo, it can be kind of confusing for us as a patient. So thank you for trying to answer. For Alex, is joint fat different from other kinds of fat, and would transplants be possible?
I love this question actually, because this is a huge question that my lab is trying to answer and that really is totally unknown in the field, because joint fat has been ignored. All right. So is it different from other kinds of fat? It absolutely is. The two main types of fat that you can think about in the body is structural fat. So think about your palms or the soles of your feet. This fat is there as like a cushion or padding. And then at the other end of the spectrum is the fat where you store your energy, right? Fat around the abdomen, thighs, arms, things like this. The fat that is associated with obesity, but has a very important role in storing energy. So I actually think that joint fat doesn't really fall into either of these categories. Sure, it can store energy, and sure, I mentioned that it can provide some cushioning, but there are these amazing other functions which we're starting to discover about joint fat, that it's very, very dynamic and potentially has this regenerative function as well. So joint fat is different to other types of fat in the body. And then to the second part of the question about transplants, this is something that actually is done in clinical practice to some extent. People in the audience might have heard of adipose-derived stem cell implantation for trying to treat joint diseases like OA. So it's worth noting that this treatment or this therapy is not shown to be beneficial. And in some cases, actually, it's been shown to cause more damage in the joint. And I think that the reason for this is that we just simply don't know enough about the stem cells that are being pulled out of fat from other parts of the body and then transplanted. We haven't characterized them well enough. And then another issue, and I touched on this briefly in the talk, was say these stem cells are perfect for regenerating cartilage or soft tissues in the joint. You put them into an OA joint and they hate it because there's inflammation and there's swelling and there's the environment is just not somewhere that they're comfortable. And so I think trying to re-engineer the environment within the joint in parallel to these stem cell therapies or adipose-derived therapies is going to be really critical.
Thank you. Our next question is, having a few different autoimmune diseases, including RA, should I request tests for potential OA? And if so, what tests should I ask for?
Should I take on this? No, I think this has to be consulted with your doctor. if you really have some symptoms, you worry that could potentially be OA, you should really talk to your doctor and make sure you do the right test before you make any decisions. Yeah.
Yeah, absolutely. I agree with that. I will say that rheumatoid arthritis, for instance, is a very different disease to osteoarthritis, very different cause and disease etiology, or the life history of the disease. But having said that, there are situations where you might suddenly start to feel more pain or different pain or worsening symptoms. And this would be a perfect opportunity to go and consult a health professional, maybe to get some further scans or tests to see if OA is beginning to set in, for sure.
Excellent. And my next question is for Shouan. Did you take a look at the changes of medial meniscus in the GH deficient mouse compared to WT?
So we have not looked at the meniscus in particular, but we have all the joints collected, freezer and other places stored. We can certainly look at them. You're muted, Jenny.
Sorry about that. Any suggestions on diet and specific exercise regimen? Also, is there any data on the effectiveness of the mushroom and its effect on OA? And I think it's a specific mushroom that I have not heard of.
Yeah, cordyceps mushroom. Yeah, that's a tricky one. So I'll start with the first part of the question. Is it all right if I field this one, Shouan, for now? So I can't prescribe any cure-all diet and exercise regimen. But diet's a pretty easy one, right? I think it's kind of obvious if you walk the aisles of the supermarket which foods are going to be better for you and which ones are going to be worse. So kind of my blanket recommendation is always fresh and unprocessed is better. And then exercise is going to be very tailored to your specific circumstances. Your age, sex, comorbidities and co-disabilities, things like that. But I did mention the mantra, like use it or lose it. And I strongly believe that doing exercise, being active, whether it's going for a walk around the block or at the park, or if it's doing really hardcore resistance or cardio training, these things are all far better than taking the cautious approach of just sitting on the couch or laying in bed because you're worried that it might aggravate your disease. So yeah, I would speak to your primary care provider and then maybe a physical therapist or even to get a personal trainer if you're able to, and they will help you with your kind of step-by-step exercise regimen. And then very quickly about the mushroom, it's this cordyceps extract is super popular these days, right, in different coffees and supplements. I don't think there's any proven link about it helping OA. I don't think it's a bad thing, but I don't think it's been shown to help in any way.
Okay, and I also want to let everyone know that there's actually a really great webinar with the Arthritis National Research Foundation, and it is on microbiome on diet for people living with arthritis. So be sure to check out the website for that. And let's see, our next question. I developed OA overnight with no warning signs. Is this typical? Wow.
Overnight means like diagnosed by doctors or just the pain start to develop?
My guess is symptoms. I don't think they said.
Okay, yeah. I mean, I can just speak a little bit about this. So OA has all kinds of groups. Some osteoarthritis, they may not have symptom until it's too late. It's very late at the end stage. Some may have like the pain symptom from the very beginning, even before the structural changes. So it's kind of hard to know what context you're talking about. But again, if there's something you need to worry, you're worried about, definitely talk to a doctor about this.
Okay, and our next question is for Dr. Knights. Any recommendations to rebuild joint fat in terms of special nutrition?
Sadly, no. I don't have any recommendations because we don't know how to rebuild joint fat. That's the simple answer. Joint fat is kind of peculiar because it doesn't correlate with BMI. So typically in obesity, as you gain weight and your BMI increases, it's very tightly associated with increases in like abdominal, visceral fat, the typical fat that you think of. But there doesn't seem to be a link with joint fat, right? Your knee doesn't become obese necessarily. And so joint fat's very mysterious in that sense. And we need to try and get to the bottom of how we can rebuild it, so to speak. And whether there's also a question of quantity versus quality. All right. Do you want more fat? So do you maybe want to restore fat that was lost? And then at the same time, you want to make sure it's the right type of fat. And maybe not the type of fat that is typically associated with obesity, which is more toxic, disease associated.
Okay, and my next question is for Dr. Shouan. Is there any evidence that people that live excessively long, like 100 plus, have changes in their GH receptors?
Yeah. So the Lemmer syndrome I just mentioned was rare genetic mutation in growth hormone receptor. So these patients, on average, live longer than normal people. There's actually a report on the health of these patients, like in their joints. They also tend to have less osteoarthritis even when they're very old.
What inspired you to research this area?
Is that for me?
It didn't say. Let's see here. Oh, it says for both.
Okay. So I started studying osteoarthritis from the first day of my graduate school. I was drawn by the complexity of this disease, and also the fact that there's no disease-modified drug available for OA. That's sort of my initial motivation into this. And the most I studied this during my postdoc, during my independent research career, the more I find it fascinating. So
I guess I have a different backstory to Shouan. I actually kind of fell into OA research very serendipitously. I spent my PhD and early postdoc studying obesity, systemic inflammation, liver disease. And then partway during my postdoc training in Michigan, I had this amazing opportunity to work with some mentors in orthopedic surgery to start studying OA. And so I really did fall into it accidentally and just became so fascinated with the joint as an organ, the different tissues, how they talk with each other, and the underlying mystery of how to solve these joint problems. And that's fascinated me ever since. So that's kind of my origin story.
All right, our next question. How does RA pain differ from OA pain?
Yeah,
I'll,
go ahead.
I'll quickly say one thing, and that is that pain can be sensed differently and manifest differently in different people, different diseases. It's a very individual-based phenomenon. And one major difference with RA is it often manifests in multiple joints. And then, whereas OA is usually more confined to a single joint, maybe a few joints. And so often the RA pain is more of a systemic thing and is a little bit cyclical in terms of when it manifests, even during the day, during the seasons, that sort of thing. Over to you, Shouan.
No, I was going to say the same. Yeah, but you definitely answered that better than me. So
Let's see here. Looking over these. And well, and honestly, if it's okay, I can answer as a patient because I live with both. And what happened to me is at my last doctor's appointment with my rheumatologist, I was complaining about some aches and pains, and she was feeling my joints. And that's when she said, "Oh, it's your osteo, not your RA." And that's how I found out I have osteoarthritis. And so sometimes you just don't know. It might seem like it's one thing, but it's actually another. So that's my 2 cents as a patient. But let's see here. Where were we? What future trends do you foresee in the field of research related to OA? And I think this question is for both of you.
I can answer first. I think when the field just started, people, especially the researcher, just focused on studying the cartilage, where most of people think the degeneration happens. I think that the field now start to recognize osteoarthritis not just happen to the cartilage, but also happen to other tissues within the joint, as Alex just mentioned. It can happen to the fat, happen to the ligaments, and also the subchondral bone. I think that's one of the direction this field is heading to, just to recognize the joint as a whole joint disease, the OA as a whole joint disease. And the second point I want to mention that the OA also start to be recognized as systemic disease, not just happen to the knee joint, but also as a metabolism in the whole body system can also affect the knee joint. Just recognized as a systemic disease, that's also another direction the field is heading to.
Yeah, I couldn't have said it better myself. That's exactly right. Maybe in terms of approaches for studying the disease, right? Artificial intelligence and machine learning are becoming very popular in research. And so in the OA field, people are trying to apply these technologies to better understand imaging results, to analyze high throughput data, right? There's a lot of sequencing that is done these days, and we are just absolutely flooded with data and we don't know what to do with it. And so these AI and machine learning approaches hopefully will help us to try and figure everything out and put it into something that we can nicely package and understand and then apply towards treatment. So I think that's one big thing in the field is the technological advances.
Is there a way for patients to be part of your research? And this question is for both of you.
Not our lab. So basically, studying basic science of the OA. Sometimes we will try to collect some our cartilage, either from the total knee replacement surgery, or from other resources. I think that's the only thing we have collected from the clinic so far. Yeah, I don't know about the direct participation in our own research.
I'll chime in and say yes, absolutely. I wouldn't suggest just rocking up at the lab and knocking on the door, but there are some fantastic avenues for getting involved with clinical research. If you're suffering from OA, or if you've had a joint injury, for instance, and might be predisposed to developing OA, these are typically coordinated through the clinical side of a hospital or a university research institute. They often have clinical research coordinators who work with, say, the rheumatologists or the orthopedic surgeons. And this is really the best in. Often there are flyers and banners around that will kind of introduce you to some of the research opportunities and that you can participate in. So that's how I would recommend to get involved with these sorts of things. And then once you're in, that's kind of where people like Shouan and I might come into the equation. It's like analyzing samples, tracking them, doing these sorts of things with the samples that are procured through these research studies.
And I'll answer from a patient perspective also, because I've participated. And so there are studies out there and there's companies out there that you can sign up for. And once you sign up, you're in their system. And once they see something that is geared towards what it is you have, they send you an email and you fill out a form, see if you qualify. So that's probably the easiest way. Let's go back here. Okay, so Alex, the next question is for you. Does joint fat reduction have any relation to increasing pain in the knee?
That's a great question. And I know I keep saying that we don't know, but the fact is we don't know. It's actually this kind of conundrum, the link between joint fat and pain, because joint fat is very heavily innervated. There are a lot of nerves which spread through the fat in the joint. And ordinarily, these nerves serve an important purpose. You want to know when something hits your knee and to retract your knee or whatever, right? They serve a very important physiological purpose, these nerves. But they can become pathological in OA, and that's why people experience such severe pain. And so I don't know if really there is a link drawn between the amount of fat, more or less, and then the amount of pain, more or less. It could really go both ways. I think you could have a lot of fat that has normal innervation with regular nerve sensors, I guess. You could have a small amount of fat. It's reduced as the disease progresses, but it could be laced with really sensitive nociceptors, which are the pain-sensing neurons. So unfortunately, I don't have a good answer for that, and we don't know yet, but I'll try and figure it out.
Let's see here. Okay, how can a person stay informed about the latest research developments in our disease area?
I think ANRF has a website listed the latest development in the research. The ANRF website. Maybe somebody can post it in the question.
Okay, I think that's our final question, and I think we're going to turn it back over to Jenny.
Hi, everyone. Thank you so much for adding your questions in. We really appreciate hearing what you're interested in. As we wrap up, I want to say thank you so much to our fantastic moderator, Jenny. We so appreciate you being here and sharing your story. Also to our wonderful researchers for sharing their innovative work towards understanding osteoarthritis. You really can see firsthand the impact ANRF has in supporting these incredible individuals on their quest for a cure. Thank you to all of you who joined us today for this great event. If you enjoyed this webinar, we would kindly ask you to consider making a donation. Join us with your support at curearthritis.org/donate. Every contribution helps, and we love to steward your donations in really giving back and bringing things like this to you and supporting our researchers as much as we possibly can. So we'll be sending our live attendees a survey after the event. Your feedback really helps us find direction for future webinars. Please do share your comments with us so we can continue providing important content for you, relevant content to you. And please don't forget to sign up for the rest of our Researcher Spotlight webinar series. So we'll be live at the same time on September 10th with lupus, September 24th with spondyloarthritis, October 8th with Sjogren's disease, and October 22nd with rheumatoid arthritis. So we hope to see you there. Thank you all for coming, and please do remember to follow us on social media. We'd love to stay connected. Have a great day.